Good morning. We're going to get started. It is my pleasure to introduce our visiting professor, Dr. Prabhakar. He has an extraordinarily impressive CV, and I only have time to share with you just a very small bit of it before I let him get up here and speak. But his training was at Bangalore Medical College and then an MD at the All India Medical School in Delhi, where he also went on to train in cardiology. He has a Master's of Science from McMaster University. He has a number of really interesting items on his CV, and before I tell you what he does now, I was just talking to him about the thousands of invasive right-sided and left-sided procedures that he did when he was a cardiology consultant, both in clinic, in the CCU, and then in the hemodynamics lab at Ames. And we were talking about his experience with mitral commissurotomies and balloon valvuloplasties. Really interesting, and I suspect will have absolutely nothing to do with what he talks about today, but I just thought that I should put that out there to sort of give you a sense of how broad his experience is as one of the leading cardiologists in India and really one of the leading cardiovascular researchers in the world. He is both a cardiologist and also an epidemiologist. He is currently the Vice President for Research and Policy at the Public Health Foundation of India and also Executive Director of the Center for Chronic Disease Control in New Delhi. He is a professor of epidemiology at the London School of Hygiene and Tropical Medicine. He heads the Center for Control of Chronic Conditions at the Public Health Foundation India, which is a joint effort between 4 organizations: the Public Health Foundation itself, the London School of Hygiene and Tropical Medicine, the All India Institute of Medical Science, and Emory University. His work ranges from mechanistic studies to trials to population-based studies and registries, and he has a particular interest in understanding the mechanisms of cardiovascular disease in South Asia and among South Asians. His work has led him to be appointed as a Fellow of the Royal College of Physicians and the National Academy of Science of India. He's an adjunct professor at Emory University. You get the sense, like I can go on and on, right? He is currently on the Executive Council of the International Society of Hypertension and Chair of the International Society of Cardiovascular Epidemiology and Prevention. So moving on to his funding, which has included NHLBI, Wellcome Trust, the European Commission, WHO, ICMR in India, and a range of other major funders. He has over 375 scholarly papers on his CV, and he is leading an effort called the Disease Control Priorities Project, which is a global effort funded by the Gates Foundation to examine the interventions that will work best in resource-limited settings. He leads the cardiovascular text on that, and that's one of the places where I've had the wonderful opportunity to work with him. He is also, maybe most important, I think, leading our efforts to understand the global and Indian burden of cardiovascular disease, especially at the subnational level, which is work he and I have been sharing for the last year or two. So it's really my great pleasure and honor to welcome Dr. Prabhakar to Seattle and to speak with us this morning.
Thank you, Greg, for that very kind introduction, and a very good morning to everyone. You were very kind enough to paint a very rosy picture of my tenure as a consultant cardiologist. So if I have to tell about my research output at that time, you would be appalled, because I had 10 publications in 12 years as a consultant, and all bad publications. But then I moved into research and started focusing on what really mattered for Indians, to understand why do Indians have such a high burden of cardiovascular disease, why do they have such a high propensity for cardiovascular disease and diabetes, and what are the potential solutions that we could offer in terms of reducing this burden. So with that in focus, I thought I'll talk about 3 things: the determinants, dynamics and dimensions of cardiovascular disease in Indians, There are some paradoxes of cardiovascular disease in India. I'll discuss those, some of the challenges that we face, and some potential solutions and innovations that we can offer. So the whole thing started almost 58 years back. There was a paper which was published in the American Heart Journal in 1958 from Singapore, which looked at ethnic differences in coronary heart disease amongst Indians in Singapore as compared to other populations like the Chinese and the Malays in Singapore. And just looking at the table, you would realize that the cardiovascular disease mortality was almost 2 to 3 times higher amongst Indians as compared to other ethnic population. It was particularly high when compared to the Chinese population. And the age-specific coronary heart disease mortality amongst those between 40 to 49 years was almost 5 times higher, 5 or 6 times higher. So this was not an isolated publication, but there were several from countries like Uganda, Singapore, a large number of publications from UK, which all showed that Indians died of coronary artery disease at a much younger age as compared to other populations, and they had a very high propensity to develop coronary artery disease. Now coming back to the current scenario, if we were to write an obituary in India in the year 2015, we would say that cardiovascular disease is the leading cause of death in India. It's almost a third of the deaths in India that is because of cardiovascular diseases. Leading the pack is ischemic heart disease, and in the parenthesis in this table is the world average. And you can see for all varieties of cardiovascular disease except cerebrovascular disease, Indians have a higher number. And in terms of total CVD, again, it is almost 30-40% higher as compared to other populations. Forecasting for the future, we are going to land up into a major problem because the number of people living with cardiovascular risk factors is going to rise exponentially. For example, in the year 2008, we had almost 140 million people with hypertension, which is likely to increase 214 million by the year 2030. Now you might wonder, why have I given these 4 numbers for diabetes? 30 in 2000 and 61 in 2011. The reason is because it's a very fast changing scenario. In the year 2000, there were 30 million people with diabetes in India, and it was predicted by the year 2025 it will reach 65 million. It has happened already. And currently we have 69 million people with diabetes in India, likely to increase to 124 million by the year 2030. A million people die because of tobacco, and it's likely to increase to 2 million people by the year 2030. And the number of people who die because of cardiovascular disease is around 3 million, which is likely to increase to 4 million. So clearly we are sitting on a ticking time bomb, so to say. But let us look at some of the interesting paradoxes that we observe in the ischemic heart disease and stroke. On the right side, we have a bar graph on the high income countries, and in the middle is the global averages. So normally the ischemic heart disease to stroke ratio is around 1 to 1.2 on an average, but as the countries improve in their economy, as we move towards developed countries, this ratio becomes 1.5. And the ischemic to hemorrhagic stroke also becomes higher as we move along the trajectory of economic development. But look at India. It's very interesting because in India, the ratio for ischemic heart disease to stroke is 2, even higher than some of the developed countries' ratio, because that's around 1.5 or so. So clearly saying that there is something which is different in Indians. And when you look at the ischemic to hemorrhagic stroke ratio, it's much lower, which means it's almost close to sub-Saharan African countries where hemorrhagic strokes are higher. Earlier in the phases of development, you have high proportion of hemorrhagic stroke. So there are 2 paradoxes here. As far as ischemic heart disease is concerned, India behaves like a developed country, and as far as stroke is concerned, it behaves like sub-Saharan Africa. So we live in straddle 2 worlds. The question is, how do we explain these paradoxes, and why are Indians more susceptible to coronary heart disease? So for this, I invoke the Omron hypothesis. In 1971, Omron and colleagues proposed that countries across the world undergo an epidemiological transition. There are transitions that occur because of several reasons. There's a demographic transition, people grow older. There's a health transition where we move from infectious diseases to man-made or degenerative diseases, and so on. I mean, there's a nutrition transition where from natural agrarian type of foods that come with that kind of economy to a very processed food kind of economy. So there are several changes that happen. Indeed, when you look at the history of mankind, there have been two major changes. One, several millions of years back or several thousands of years back, man became an hunter-gatherer to an agriculturist. And when man became an agriculturist, infectious diseases increased. And it remained so till the 17th century when the Industrial Revolution happened and we started observing some of these chronic diseases. But to have the peak of epidemic of chronic disease, it took nearly 200 years in the United States, from 1700 to 1950s or so. Whereas in India, it's just taken 50 years because we had a similar situation as what US had in the early part of the 20th century in 1950s when India attained independence. Within a matter of 50 years, the proportion of cardiovascular disease and chronic disease has increased manifold. So it has been a very compressed transition, and therefore we have a slightly different pattern as we have observed in other parts of the world. So if you look at the health transition profile, when you are in the very early stage of transition, the life expectancy is 35 years, and the major cardiovascular disease would be rheumatic heart disease and nutritional cardiomyopathies such as beriberi and those kind of diseases which we hardly ever observe now. In the second stage, the life expectancy increases to 50 years, and the most significant cardiovascular problem would be high blood pressure or hypertension, which actually results in hemorrhagic stroke. Then moving along the trajectory, the life expectancy increases to 60 years, where we start observing coronary heart disease and both forms of stroke, the ischemic form of stroke as well as a hemorrhagic form of stroke. Then further along the line is stage 4, where the United States and most of the Western countries are in, where life expectancy is more than 70 years, where people have largely coronary heart disease and thrombotic stroke. But countries like the former Soviet Union and Russia actually have slipped back because of several reasons, and that is called as stage 5, which is reversal to stage 3. You achieve public health goals of reducing cardiovascular disease, but it comes back again, and that's the stage which Russia is in. And stage 6 is considered as a mix of different stages. There have been several modifications to this classifications, but this is in general what happens as countries progress along the path of development. Now, why is this hemorrhagic stroke, ischemic stroke different in different economies? It starts with high blood pressure becoming the major cardiovascular disease risk factor by the time a country moves to stage 2. And hemorrhagic stroke and hypertensive heart failure, which we observe in countries like countries of Africa, becomes widely prevalent. Many parts of sub-Saharan Africa are in stage 2 of the transition. But as other risk factors start appearing, use of tobacco, smoking increase, and diabetes start appearing, we get more of thrombotic stroke and coronary heart disease. And that's what is happening because, as I was telling someone, I gave a lecture a few years back, that India lives in multiple centuries. You can have 21st or even a 22nd century care in India, but you could also have a 17th century care in some parts of India. So it lives in multiple centuries, and India has multiple countries. So you could have US type of care somewhere, and you could have a sub-Saharan African type of care. So you have both the problems. So the next part of my question is, why are Indians more susceptible to coronary heart disease? So most people say that it's probably genetic or a fetal programming that occurs, and there's an interaction with environmental factors. Now, one of the things which has been spoken about largely about Indians is the high degree of risk for diabetes. And in fact, in 1907, Indian physician said, what gout is to the aristocracy of Britain, diabetes is to the aristocracy of India. The only thing that has happened is the British have left India, but diabetes has moved beyond aristocracy to the poorest sections of the society in India. If I ask this audience or any audience for that matter, what are the popular views regarding why diabetes occurs, most people would say, it's a combination of factors. It's lifestyle changes because of globalization and urbanization, resulting in overweight and obesity, which results in hyperinsulinemia, insulin resistance, and resulting in diabetes or impaired glucose tolerance. Some people would attribute it to genetics, and some people would say it's an interaction between in a genetically predisposed individuals. You impose lifestyle changes, and therefore you develop diabetes. But let's look at genes and diabetes. Known single nucleotide polymorphisms explain only 14% of all cases worldwide. This is known from multiple systematic reviews that have been conducted. Common variants of genes are similar to all the populations. It is not that there are special genes in genetic polymorphisms in South Asians or in other populations. They're all present across the world. There is very little concordance between the genes that determine obesity and the genes that determine diabetes. They're actually different. You would think that the FTO gene, which imposes a very high risk for obesity, would cause diabetes, but that's not the case. Adding genomics to very simple measures such as weight, for example, does not improve prediction of the risk of diabetes, and lifestyle interventions almost negate the high genetic risk that an individual may have. So this figure is just to show the obesity type 2 discordance. The bolded polymorphisms are the obesity polymorphisms, but when you look at the several polymorphisms of diabetes, they don't actually figure in that common area where obesity diabetes interaction would be there. There are very few gene polymorphisms which are common between diabetes and obesity. So there's obviously huge discordance. Now moving on, let's do another comparison. We can do an ecological comparison between say 4 countries like United States, China, Japan and India. This is from the WHO NCD country profiles in 2011. Overweight and obesity defined as BMI greater than 25 was observed in almost 2/3 of the US population. In China it was a third, in India it was around 13%, and in Japan 29%. And look at the prevalence of diabetes. The prevalence of diabetes in the United States, India and China were exactly similar. Now how do we explain this phenomenon when you have such a variation in BMI, such a variation in obesity and overweight, but a remarkably similar prevalence in diabetes? So the next question that you would ask is it, suppose we look at different ethnicities living in the same population, living in the same environment, it would be different. Because if environment had to have a major role, it could get nullified. So this is what we looked at the second panel. And this is a publication from one of my colleagues with whom I worked, Venkat Narayan and his PhD student. When they looked at diabetes prevalence by BMI and the region of origin, where did these people come from, it is very clearly evident people who came from Indian subcontinent had a very high prevalence of diabetes. And when you look at this line, which says that for European origin people, the prevalence of diabetes touched nearly 8 to 10% when the BMIs were above 30. That means when they became obese. But you look at Indians, it's at the same level. Even within normal weight, they have the same prevalence of diabetes as an European origin person. So clearly indicating that there may be other reasons other than obesity or lifestyle changes that could explain diabetes. So we posed the question as to what are the potential reasons for the heterogeneity in the epidemiology and associations of diabetes among these different ethnicities, and there could be several. The first is there could be a reduced beta cell mass among South Asians. I'll allude to that a little bit later and explain why it should happen. There's an altered body composition. It's been shown that Indians have higher body fat content as compared to other populations across the world. Poor maternal and early child nutrition. I'll also explain how this increases the risk of diabetes. A high carbohydrate diet. Indians and South Asians in general eat rice, bread, lots of rice and lots of bread and lots of Indian sweets. So obviously there's a high carb diet. There's lipotoxicity. The role of microbiomes is coming up but has not been explored completely. Endocrine disruption through air pollution and organic pollutants could be a reason. Hepatic infections, which are very common in the Southeast Asia region, can actually destroy liver cells and increase or create fatty liver and increase hepatic insulin resistance. And some unknown reasons could be there. But let's look at one or two of these reasons and explore. I just would like to draw your attention to what I call the tale of two Indians. And this audience is well aware of the Pima Indians. The Pima Indians are a pre-Columbian migrant population in the United States who never had any major illnesses till the 1950s. And in fact, the NHLBI funded a program to, they had rheumatoid arthritis as a big problem. So they funded a grant to evaluate the reasons as to why they get rheumatoid arthritis. And during this process, blood sugar was measured, and it was found that they had a huge burden of diabetes. The diabetes was to the tune of 30-40%, and now currently it's almost 50% by the age 55 years. When you look at their obesity profile, they're very, very obese. Their mean BMI is 33.7 and mean waist circumference is 108. So they have both generalized obesity as well as regional adiposity. Their mean glucose profile. So when you look at glucose profile, you look at three things. You look at fasting glucose, one looks at 2-hour postprandial glucose, and looks at HbA1c, which is a measure of what the glucose levels would be at a long time. So when you look at their glucose profile, they have very high 2 hours plasma load glucose. So the postprandial glucose levels are high. Nearly 2/3 of their pre-diabetes is impaired glucose tolerance, which is high levels of 2-hour plasma glucose. Insulin resistance measured by HOMA-IR is 2 to 4 times, they have 2 to 4 times higher levels of insulin, and they have high levels of insulin resistance. And let us look at Asian Indians. The prevalence of diabetes in Chennai population, because this is done in Chennai, was very, very similar. Chennai is a city in the south of India. But the obesity profile, these are very relatively thinner individuals. The mean BMI is around 25 and mean waist circumference is just around 83 centimeters. You see the remarkable difference between Pima Indians and Indians. In fact, in this population, a third of people with diabetes had a BMI less than 18, which is considered as undernourishment. In terms of glucose profile, it was very different. In fact, the fasting plasma glucose levels were higher. Clinicians who treat diabetes among South Asians find it extremely difficult to control the fasting blood sugars, whereas for other populations it's much easier. And over 2/3 of the pre-diabetes in the Indian population was impaired fasting glucose. And half to 1/3 of insulin secretion was observed in Pima Indians. Pima Indians had nearly 2 to 4 times insulin secretion following a glucose challenge, whereas Indians had much less as compared to Pima Indians. So clearly there are two different phenotypes that we are talking about. So we looked at another study which was again done in India and in the US, which looked at oral disposition index, which measures insulin sensitivity, which measures insulin secretion levels. And as you can see here, at even very early on in the pathway to diabetes at impaired fasting glucose, South Asians have very low disposition index, which means they have very low secretion of insulin. And as the disease progresses, they start acquiring insulin resistance, as well as the disposition index starts falling. So there is a combination of low levels of insulin secretion and high levels of insulin resistance. So to hypothesize, we have two types of beta cell capacity. One which is a narrow beta cell capacity, which is found in South Asians, and second, there is a wide beta cell capacity which is found in populations such as Pima Indians. So in the narrow beta cell capacity, people start having impaired fasting glucose, and which progresses to impaired fasting glucose plus diabetes. So in the basal metabolic states, there's high fasting glucose, slight or moderate demands for insulin leads to strained beta cells and very early acceleration to diabetes, and the predominant form of prediabetes is impaired fasting glucose. On the other hand, when you have wide beta cell capacity, your basal metabolic state, the fasting glucose is nearly normal, and slight or moderate demands for insulin are managed very efficiently by increasing insulin secretion. And the dominant form of pre-diabetes is impaired glucose tolerance. And the conversion from pre-diabetes to diabetes is much slower in populations such as Pima Indians, whereas it's much faster in the Indian population. The next point I wanted to make is the body fat composition. This was published around 15 years back in the Lancet, and they called it the YY paradox. Both these gentlemen are endocrinologists, one in the UK and the other in India, Yudkin and Yajnik. And so they called it YY paradox. They got a DEXA scan done and found that they had a remarkably similar BMI. Both their BMIs were 22.3, except that Yudkin was taller and Yajnik was shorter. But when they looked at their DEXA scan, the body fat content in Yudkin was 9% and Yajnik was 21%. So you might say this is one-off, and these are anecdotal. But there have been several studies across the world which has shown at any BMI, Asian Indians have a very high percentage of body fat, so that they are metabolically obese. They may be thin, but they are metabolically obese. And the second problem is the visceral fat mass is higher for Asians as compared to Caucasians. So even amongst neonates when they are born, Indian kids have what is called as thin fat phenotype. They are very thin, but the body fat content is higher. So clearly, and especially when you are depositing fat in the omental and the pre-omental area, they are chances of becoming metabolically active, secreting inflammatory products and increasing the levels of diabetes. The third reason that has been alluded to the high burden of diabetes is low birth weight and undernutrition. If we were to draw the world map in terms of low birth weight and under 5 undernutrition, look at the size of India. India would occupy almost half the world's map. And similar is the case for diabetes. How are these two paradoxical things related? How do we explain this ubiquitous relationship between low birth weight and diabetes? So we get back to the old hypothesis by David Barker from University of Southampton and Forstall from Norway, who said that there is a fetal programming. A stimulus or an insult at a sensitive or critical period of development has lasting or lifelong significance in terms of structure. They said that because the fetus is undernourished, it has to protect itself. So there's a brain sparing effect, and the blood supply to the liver, the pancreas and the kidneys are decreased, and the number of glomeruli or the number of islets would be decreased. And there's alteration in physiology because the fetus has to survive, so the deposition of fat and the metabolism is very different, and therefore they are prone to adult onset chronic diseases. And there are more than 100 publications in multiple countries, both Western as well as the developing countries, which shows that low birth weight is associated with rebound adiposity, hypertension, coronary artery disease, type 2 diabetes and stroke. And the other issue is that a low birth weight, a shorter mother begets a shorter girl child, and there are epigenetic changes that have been shown to occur amongst shorter mothers who beget shorter children, especially there are changes in the oocytes which are permanent. So therefore there is a social problem which is transmitted across generation, and these epigenetic changes because of social causes can affect 3 generations. We also further looked, we know that low birth weight increases the risk for diabetes, but what happens, how does it interact with childhood obesity? So we have a birth cohort which we have been following from the years 1969 to 72. These were children born in the years 1969 to 72, and they're currently around 40 years plus. And we have had several measurements of these people. And what we have observed is prevalence of dysglycemia, or defined as impaired glucose tolerance or diabetes, is inversely related to weight and BMI at 1 year of age. And the highest prevalence of diabetes or impaired glucose tolerance were in subjects who were in the lowest third of the group with respect to BMI at 2 years and highest at age 12 years. So there's a double whammy here. You start off with low birth weight, you have a higher risk. But if you put on a little bit of weight as a child, then you have higher risk of developing diabetes as an adult. Now this is the graph which shows that people who had the best profile in terms of glucose is in the green line, and the worst profile is in the red line. So people who want to develop diabetes start off with a lower birth weight. Their weight starts decreasing by up to 2 years, and then they start putting on weight. But the fact is they're not obese. Their weight is higher than the cohort mean. So just that slight increase in weight actually results in a higher propensity to diabetes. So studying the fetal origin of heart disease is very important. In fact, the romantic poet Samuel Coleridge in the 19th century said the history of man for 9 months preceding his birth would probably be far more interesting and contains events of greater moment than all 10 years that follow it. I mean, I would say this is a remarkable prescience to have predicted that. So we need a life course perspective. CVD and coronary heart disease risk accumulates starting early in life and is influenced by socioeconomic position at all stages of life. And as you can see, that we have fetal programming, we have a genetic background, we have early childhood and childhood obesity, and adolescence where again obesity plays a factor. And as you move along the adult life, if you're poor, you start smoking more, acquire other risk factors, and go on to develop cardiovascular disease. I think this kind of explains the reasons for some of the high burden of cardiovascular disease. But there could be others. There are other emerging areas of research in diabetes and cardiovascular disease. One, there's been a systematic review which shows that organic pollutants could actually increase the risk for diabetes, and we are studying this from our cohort that we have established. We're looking at incident diabetes and looking at 10 organic pollutants. The results will be available by the end of this year or early next year. The second is environmental factors, built environment. How does it impact cardiovascular disease or diabetes? So we have geocoded our cohorts, looked at several of the factors that could influence cardiovascular disease: the presence of health facilities, physical activity, environment, food environment, alcohol outlets, transportation, and schools and nurseries. And we have been obtaining very interesting findings, and this requires validation. When we classify groups of people as having low physical activity, it is the same group of people who have high blood sugar levels. But look at the area where these people reside. There's a highway, there's no greenery, very clustered houses, and no place to exercise, actually, no parks, nothing. But on the other hand, when you look at neighborhoods which have presence of large parks, this is for looking at depression, which is another comorbidity with diabetes. People who were closer to the parks had lesser depression as compared to people who lived far away from the parks. So these are very preliminary findings, requires validation, but very, very interesting findings that we have. The next issue is about air pollution, and we have been talking about air pollution causing endocrine disruption, and we have created an air pollution model for Delhi and Chennai which goes back to 1980s, and so we can actually look at average air pollution levels over the years and look at the incidence of diabetes and cardiovascular disease. So if I have to summarize as to why do Indians have a high burden of coronary artery disease and diabetes, obviously it starts with changes that happen across the country, that includes globalization and urbanization, resulting in lifestyle changes, changes in diet, physical activity, and tobacco. The presence increasing the coronary artery disease risk factors and increasing coronary heart disease morbidity and mortality. Availability and access to care is an important issue, and it is conditioned by the background genetics and fetal programming. Poverty, education, stress, and life course socioeconomic status could be other issues, but there are new and emerging factors such as air pollution which would be explanatory. So I would say coronary artery disease in Indians or any population starts in the womb and ends in the tomb, and therefore we require to go beyond our comfort zones. I now briefly move to the second part of my talk and speak for 15 minutes as to how do we address this burden, how do we address this high risk. So we have understood some of the mechanisms and some of the causes. What are the approaches that we need to take if we have to address it at a population level or at an individual level? Health systems is at the intersection of both the population approaches as well as individual approaches. We need a good, robust surveillance and screening mechanism. We need to understand mechanisms more clearly. We need health system interventions such as task shifting and task sharing, and particularly provision of care and financial protections needed for people who have catastrophic illness such as myocardial infarction or stroke. In fact, it is the third most important reason for Indians falling below poverty line. If you have a heart attack or a stroke, the chances of becoming poorer is quite high, and it is the third important causes annually for people getting down into a poorer level. Then individual approaches includes innovations in the management of acute illness, secondary prevention, and personalized risk assessment and primary prevention. In terms of surveillance and cohorts, we have established one of the largest urban cohort model surveillance study in South Asia with more than 30,000 individuals from communities of Delhi, Chennai, and Karachi in Pakistan. We are one of the largest rural cohort in India, and we have a cohort in transitioning cities, which are between rural areas and the highly metropolitan cities, which are just moving from a agrarian population to a highly metropolitan population. And we have collected data of several demographic, behavioral, anthropometric, and blood measurements. But this is a huge platform for young investigators. In fact, I wanted to make this point because many of the American fellows who worked with me have worked on this project. They have written papers and they have continued to work and are looking at K awards and RO awards and work on some of these platforms that we have developed. In fact, we have created a biorepository with almost 500,000 aliquots with different components of blood, urine, saliva, and so on, in long-term storage. So this is one of the mechanistic aspects of research that we do. But more important is the research that we do in terms of improving outcomes for people, which is task shifting and simple technology, which is at the core of our work to address the burden of hypertension and other NCDs in India. So this aims to improve access to care. It has ability for complex computing and aids in task shifting and sharing. So when I mean task shifting, some of the tasks of a specialist could go down to a primary care physicians. The tasks of a primary care physicians could be performed by a nurse, and the tasks of a nurse could be performed by a community health worker or a frontline health worker. And so many of the diseases that we address in chronic disease space can actually be catered to these lower level personnel. Particularly the frontline health workers have a major role to play in addressing the burden in India. So it standardizes care, improves quality, and reduces medical errors. It tracks patient outcomes and provides data for refining techniques and methods, and actually provides a very personalized advice to each of the patients. And we developed many of these programs and did trials at various locations, including primary healthcare centers, secondary healthcare centers, tertiary care centers, teaching hospitals. So at all levels of care, we have evaluated. Yesterday I was talking to Greg and he was mentioning the SIM card trial, which was published in Circulation a few years back, 2 years back. It was a study done in Tibet in China, one of the poorest areas of China and one of the poorest areas of India, where we recruited community health workers, provided them with this electronic decision support system for screening and referring patients, and we said that they just needed to have a 2x2 intervention. The first 2 interventions related to blood pressure drugs, and the second intervention related to counseling for diet and tobacco. And at the end of 1 year, the blood pressure in the group which had the intervention was much better as compared to the control group. So clearly simple things like this can make a major change. There are too many studies to discuss, so I'm not going to discuss all. I'm just going to give one example of how we scaled up one of the decision support systems that we developed, which we call it as the Empower study. It was a tool which was developed for screening for hypertension and diabetes, had a 10-year risk score for cardiovascular disease. It had a personalized clinical management plan, had an electronic health record for doctors in the health system. It could provide advice on optimal drugs and dosage, on lifestyle, prompt drug contraindications. So there are several features. It had the flexibility to address the evolving clinical management guidelines. It had a stable platform. You could get real-time data. It had secured central server with backup data, and there was data interoperability. One of the problems which I was discussing with you yesterday was the issue of interoperability, because many of these electronic health records can function only in one platform and it won't function in another, and ours had this functionality. So this we implemented in 6 outpatient clinics in a rural population over a 21-month period, and recruited around 6,800 patients. The two important features which I want to highlight here is 50% of these patients were newly detected. If not for this system, they would have never been detected to have hypertension or diabetes. And second, if you look at the graphs, there was a substantial fall in blood pressure, systolic blood pressure, as well as blood sugar, and it continued to remain at that same level even up to 18 months of follow-up. So First is we did a trial, then we did an implementation science. This is what we're showing in this implementation science. And the third is we scaled this up across multiple states. So this particular program is being used in many of the government hospitals in 2 or 3 states across the country. And it does provide, which Greg was talking about, data for big data analytics. And you can actually look at what are the things which make people take drugs, what are the things which improve the outcomes for people. So you could get many of these things by this platform. And we plan to move on to chronic kidney disease, chronic obstructive lung disease, asthma, cancer, and other comorbidities. The last I would briefly touch on is quality improvement programs. One of the quality improvement programs is a large stepwise design trial, has been accepted for a late-breaking clinical trial at AHA this year, so I'm not going to talk about it now. We are also using traditional approaches such as yoga for cardiac rehabilitation, because yoga is intuitively much cheaper and acceptable to the Indian population. And we work in the area of improving human resources. So the big problem in India is a shortage of doctors, shortage of specialists, and primary care physicians are very averse to treating chronic diseases because they are highly insecure. We have created a standardized training program all across India, which can be delivered all across India by trained trainers on a designated day. And this has become extremely popular, and we have trained almost 20,000 primary care physicians under our division in the last 5 years. It has won several accolades and awards over the last few years, and in fact it won the highest Quality Council award from India just very recently. So we can't rest here, we need to look at new frontiers and innovations. Most of our interventions so far are individual based. We have not developed family interventions, and we recently worked on is there a higher risk or is there a higher concordance of chronic diseases of people living within the families? Like, for example, if somebody has diabetes in a family, is there depression which is higher amongst the spouse? So that's such questions were asked, and we recently published just 3 or 4 days back in PLOS Medicine demonstrating that there's a chronic disease concordance. So this actually opens up new vistas in terms of developing interventions at a family level. The second is to use technology, and the third is to develop and evaluate new metrics of measurement. In terms of technical innovations to decrease disparities in healthcare, there are several I've listed here. We need to improve the surveillance system, we need to improve diagnostics, we need to improve drugs, particularly polypills and fixed dose combination. We need to improve drug availability and distribution, improve access by creating virtual polyclinic using the telemedicine philosophy, and integrating care with chronic diseases and communicable diseases. So this is an example of a point of care device which one of our colleagues has developed, which is a very small program where you can do the test. Most of these tests are less than $1, and it actually loads onto the system and you get the value, and it goes into the software so you can have real-time access. The next is, for example, we have been working on very archaic methods in terms of nutrition data. We have been using food frequency questionnaires, and we've been using 24-hour dietary recall. We need to look at 5 key areas in understanding nutrition. So one is improving data on actual food intake, agreement on how to measure diet quality, metrics that measure women's roles in defining dietary choices, metrics to measure food environment within which diet choices are made, and metrics to measure the health of food systems overall. Because it's very important that all these are interlinked, and by 2032 we are supposed to achieve sustainable development goals, and nutrition is an important component, and we have been funded by Wellcome Trust to conduct a very large study looking at the role of environment and agriculture and food systems. So to conclude, addressing the challenges of CVD requires us to move beyond our comfort zones of clinical trials and basic sciences. We need to move and look at effectiveness, efficiency, availability and distribution, but also work with policymakers in terms of framing policies and look at surveillance in epidemiology. Our philosophy has been to move from bench to bedside and beyond, move from molecules to markets, and move from individuals to populations. If I have to stargaze for the future, We need to develop low-cost yet robust health management information systems, develop platforms for big data, collaborate with organizations like Google, etc., to develop state-of-art maps and update them frequently, particularly with regard to health infrastructure, creating virtual classrooms to train primary care physicians, and technologies for mass delivery of training programs at low cost. I'm going to leave you with this quote to show that the dimension of the problem that we have. So we have a lot of work to do, but I also would like to leave with an optimistic note saying that there's no incurable disease, it's only a lack of will. Thank you.
Thank you for that really fascinating talk. We have time for questions.
I have a question. I've been involved with cardiovascular prevention for many years. One of the things I found very helpful is to teach people how to take their own blood pressure so that they know whether they're winning or losing. So my question to you is, are you teaching what percentage of you know how to take their own blood pressure at home?
So I think it's a very important aspect because we need to teach people to take blood pressure, but I think one of the biggest barriers of blood pressure measurement is our sphygmomanometer itself, because it's complicated for a person to tie it and then to measure it accurately. And I think the NIBB, National Institute of Biomedical Board, which is an institute in NIH, and the Department of Science and Technology are working on simple measurement techniques such as the SaVO2 measurement tool, what is it called? The clip, so which uses differences in blood flow to measure blood pressure. So they're working on those kind of things, and I think that will make a big change. But in the meanwhile, till we get that, it's very important that we educate people in self-monitoring and self-measurement of blood pressure.
Enjoyed your presentation very much. One thing you didn't really touch on very much in your presentation was the epidemic of tobacco use in India and the impact, obviously, with the high incidence of diabetes and hypertension. So your thoughts about that? What's being done in a public policy forum, for example, on that problem?
Right. In India, actually, it's been India has done a lot of work. We have done a lot of work, and we are in trouble because of that. So I was telling others yesterday. So India actually negotiated the Framework Convention for Tobacco Control. In fact, Dr. Reddy, who's my boss, he was the chief negotiator on behalf of India and many of the developing countries, and FCTC was actually framed in 2002, and India was one of the first countries to pass it into law. Then after that was the Empower package, which was developed by WHO. India actually has laws which bans smoking in public places, sale of tobacco to minors, locating advertisement bans, and so on. One area where we have not worked is in cessation, because it's expensive. There are very few doctors who prescribe. Having said that, despite such good laws, the problems lie in the implementation of these laws. Many times the tobacco companies overcome through point of sale advertisements, which allures people into using tobacco. But having said that, over the last 5 years, there's been an absolute decrease of smoking by around 6%, which is huge. And because of that, tobacco companies have targeted our organization. In fact, they have advocated with the government, and the government has actually banned us from receiving foreign funds. So it's been a bit of an issue. We're trying to overcome that.
That's great to know that, because I think what you alluded to earlier, what's going on, India looks like the 1950s.
Yeah.
From the standpoint of coronary disease, and if you look at tobacco in the United States in the 1950s and 60s, exactly the same thing.
Yeah. There's another problem with tobacco in India, because the smoking form of tobacco is BD, which is tobacco rolled in a special form of leaf. So it's considered as cottage industry, and it is not taxed, whereas cigarettes are taxed. And so people use this, and it's much more harmful. In fact, the Interheart study showed that BD smoking is as harmful as cigarette smoking. And the third form is use of tobacco by chewing or using it as snuff.
Thanks for the talk. You very nicely laid out the potential explanations or examples of differences in Indian populations in terms of cardiovascular risk. you didn't touch on whether sort of classic sort of interventions, you know, in North America have the same impact on Indian populations. Are our therapies, you know, do they have the same outcome? Because there is this perception that, oh, we have done such a wonderful job here that all we need to do is take the same things and just move them, you know, across the
I didn't allude to that because of paucity of time. Obviously, it would have taken much more time to do that. So there are two things to your question. The first is, do we have enough evidence and do we need trials actually to demonstrate that a particular drug would be different in Indian population as compared to the US population? And there are some examples. For example, our weight is lower, and there have been studies which show that glycoprotein 2B3A inhibitors, for example, have higher bleeding amongst Indian population. Maybe the dosage needs to be decreased. Or response to statin is quite dramatic in Indians. I mean, you have LDL cholesterols of say 6 or 7, and with just 10 milligrams of atorvastatin it would just fall to 4. So there are small studies which show that. So clearly there is a need, at least if not for outcome based trials, simple demonstration trial to see which of the antihypertensives or which of the statins are good. That's number one. But the second thing is, even when there is known evidence that something works, which could be common to both the populations, it needs to be contextualized. Let's take the example of salt. Salt reduction in India has an emotional issue. In fact, the whole edifice of independence movement in India was based on salt. The salt was taxed, and that started the Quit India movement, and therefore there's an emotional connect. So it's very difficult for the Indian government to tax salt. And second thing is cooking practices. Most of the salt that's consumed in India is added to cook to food that is cooked, and while cooking they add salt, unlike in the US where it is largely processed food. So it's easier here to address that rather than, because you need to change the culture and thinking and behavior of people there. So these are two issues that needs to be addressed.
I'm really interested in this low birth weight relationship with future diabetes. Is birth weight normalized from the maternal ties? And also, what is the experience with diabetic or large babies? Do those babies have some kind of protection?
So gestational diabetes has two consequences. One, the mothers with gestational diabetes deliver largely low birth weight babies, but they also deliver macrosomic babies with high birth weight, and both are problematic. And in fact, it has been shown that children who are born with gestational diabetes have a high propensity to develop diabetes as adults. And there are interventions now. We are actually being funded by NHLBI and by MRC UK to conduct a study to reduce the incidence of diabetes amongst women who develop gestational diabetes. And therefore, you start detect it early, start managing it early, continue the management up to 2 or 3 years after the delivery to reduce the diabetes amongst women. So one thing which is not very clear, it's not been very well studied, is there are small studies to show that it increases the risk, but you don't have such robust experience as low birth weight babies.
So thank you very much for attending and for the questions, and let's thank